1955, WHO launched the Global Malaria Eradication Program. Next slide. Next slide. All right. The Global Malaria Program was launched in 1998 by the WHO, and the components of RBM include early detection through the use of rapid diagnostic tests, rapid treatment, multiple methods of treatment, well-coordinated action, dynamic and global involvement, and focused research. So it's DTTR. Early detection, rapid treatment, multimodal treatment method, and net research coupled with well-coordinated action and global involvement. Next slide. Let's continue. Next slide. It's another grammar. So, what are the control measures are aimed at the individual, the vector, and the environment and the community. At the individual level, prophylaxis, use of nets and repellents. Targeting the vector include use of adult imagicidal control, larva control, and environmental sanitation. For the community, involve community mobilization for engagement in malaria control programs and vaccine development. Next slide. The strategies required coordinated actions at the national, international, and governmental and non-governmental sectors with health education and community enlightenment as key strategies at the population level, with policy making and implementation and continuous surveillance, monitoring, and evaluation. Next slide. Next slide. Next slide. This is another grammar. Grammar. Next slide. Next slide. How many slides remain? So, okay. Next slide. These are all grammar. Nothing to. So, what are the problems with the programs for malaria control in general? Ignorance, poverty, poor funding. In summary, in conclusion, malaria during pregnancy has adverse consequences for mother and their babies. Malaria preventive packages in pregnancy include intermittent preventive treatment with sulfadoxine pyrimethamine during antenatal care visits, use of insecticide-treated net throughout pregnancy and the postpartum period, and it must be emphasized that prevention must be complemented by effective case management of malaria. So malaria vaccine is still being investigated. Next slide. We'll pass this, please. Case management must emphasize screening and prompt treatment. So it's still under development. We'll go and pass this one. Next slide. Okay. Vaccine is under development. No completely effective vaccine yet. For now, candidate vaccines involve developing antibodies against circumsporozoid protein, which causes sporozoids. They're also considering erythrocytic vaccines. It is hoped that the sequencing of the Plasmodium falciparum genome will provide targets for new drugs and vaccines. Next slide. So I think that's all. Questions, please. This lengthy malaria presentation. Any question? We have 99 slides. Wow. Okay. I want to look at obstructed labor. Now, this definition of obstructed labor is not the standard, sure. The standard definition is that labor is said to be obstructed when no further progress is possible without intervention. because failure of descent a presenting part into the maternal pelvis despite adequate contraction, rather talking about cephalopelvic disproportion or fetopelvic disproportion in general. When there's adequate contractions, but the passenger is not able to pass into the pelvis. So that's the disproportion. But obstructed labor is said to exist when no further progress in labor is possible without intervention. And these interventions could be operative vaginal deliveries or cesarean delivery. Next slide. What are the causes of obstructed labor? The causes could be maternal, such as cephalopelvic disproportion, pelvic tumors, such as huge uterine fibroids located in the lower uterine segment, ovarian cysts, cervical stenosis, or vaginal septum. These are all factors that will make it difficult for the passenger to pass through the passage. So maternal causes are mainly related to either the passenger or the passage itself. Fetal causes include impacted transverse line. The simple reason is that there's no mechanism of labor for a transverse line. It is impossible for delivery to occur. So impacted transverse line, malpresentations such as face presentation, brow presentation, even the face depends on what? Face presentation meant the posterior is impossible to deliver. Brow presentation is impossible to deliver. Breech with macrosomia is impossible to deliver. Shoulder dystocia is, of course, an obstructed labor. When you have congenital abnormalities of the fetus, such as conjoined twin, or when you have locked twins, in which the leading twin is presenting breech, it's already down the birth canal, then the second twin is cephalic and they are locked at the jaws. The malposition, fetal macrosomia, yes. Next slide. These are among the many fetal causes of obstructed labor. Next slide. So how do you anticipate that labor in this woman may likely become problematic? Now, the essence of antenatal care is to look at women that may potentially develop complications either during the pregnancy or even during labor, and therefore plan how to deal with them. So during antenatal care, there are women that you may suspect the potential for obstructed labor occurring. These women include those with maternal height less than 1.52 meters. The obstetric height is supposed to be at least 1.52 meters. This was based on a study by Lawson et al., Kelsey Harrison in Zaria, where they found that most women that develop obstructed labor were short, stunted growth. But these findings may not necessarily apply now, but just know it. Height less than 1.52 meters is important. When there's abnormal lie or abnormal presentation, when there's a history of a previous difficult labor, such as labor that was prolonged, labor that required instrumental delivery, or she requires cesarean section. This should should always remember this when you're seeing during the course of antenatal care, so that you'll be looking at factors that may have contributed. Next slide. The labor you should also anticipate. Cervical stasis is when you have a woman in labor, the cervix starts dilating, but then cervical dilatation got arrested. For 4 to 6 hours, she'll tell you there's a problem. This is different from cervical dystocia, where due to primary fibrotic disease of the cervix is unable to dilate at all despite adequate contractions. In addition, when a woman in labor has persistently high presenting part, the head or the breech has refused to engage for several hours despite adequate uterine contractions. And with this, when there's also arrest of descent, This one was progressing, then she got stuck. When there's inefficient uterine contraction, we also herald potential difficult labor that may become arrested and then prolonged and therefore obstructed. Next slide. What are the clinical features of obstructed labor? There may be a history of prolonged labor at home or in another facility. It's not all obstructed labors that are prolonged, but the majority of obstructed labors are prolonged because they might have occurred either at home or in a lower facility with inadequate staffing and inadequate skilled manpower to diagnose it. They may also have come with a history of failed instrumental delivery. So when you examine the findings that suggest obstructed labor include maternal distress. She's crying, she's in pain, she's exhausted, she's telling you, just help me with this baby. So she will look exhausted, dehydrated, terrified, and in pain. These are features suggestive of obstruction. Next slide. When you examine the abdomen, there may be obvious tense abdomen, especially if membrane has ruptured for many hours. It's already infection setting in. She may have a contracture ring in the lower abdomen, that's called bandage ring. The bladder may be distended, and because she has been dehydrated for so long, she may be passing scanty concentrated urine. Fetal heart may or may not be present. It may be there, but severe tachycardia or even bradycardia or even absent. Now, next slide. When you do vaginal examination, you may find various degrees of molding and caput. The vulva itself may be edematous, which is known as cannular sign. The presence of cannular sign syndrome is just telling you that this one is obstructed, such that even the venous return and the lymphatic return and the vagina have been impaired and everything became edematous. Then there will be severe mold. And of course, there may be offensive discharge with fever because membrane has ruptured for hours, for days, and the liquor has been infected. Next slide. Well, how do you manage? Management involves resuscitation. First is resuscitate. And because it's an emergency, one person cannot do it. So you must call for help so that you mobilize other members of the team, including the nurses, the attendants, the registrar, the senior registrar, consultant, be informed. Then immediately set up your IV access, take samples for your full blood count, urea, electrolyte, glucose and cross-match, and then you quickly resuscitate, provide fluid, so that you want to correct fluid and electrolyte imbalance, set IV line, put your ringas lactate. Of course, you have to do your random blood sugar. She's not eating for long, you have to also give her some dextrose, right? So set up your IV fluid, commence antibiotics, because especially those that have foul smelling with fever, it's already infective. You are not doing prophylaxis now, you are treating. So commence your IV antibiotics. Pass your nasogastric to decompress the stomach, because of the electrolyte derangement from obstructed labor will have caused so many widespread derangement that you have gastric, the stomach is distended, the balls are distended. So you pass your NG tube to decompress, give her antacids via the NG tube, and then give her ranitidine intravenously, pass your catheter, and then plan delivery. Of course, in the course of all this, somebody will have assessed the patient, somebody will have taken the vital signs, somebody will assess whether the fetus is alive or not, what's the presentation, and then, of course, assess the cervical dilatation and the station and what is the potential cause of the obstruction, so that the definitive mode of delivery will be decided. Next slide. So what are the operations? You may do an operative vaginal delivery. You can do vacuum, you can do forceps. Now, usually with obstructed labor, it's usually not possible to do, sometimes it's not possible to do vacuum because of severe caput. When you have severe couple, you'll not be able to identify your fontanels. Therefore, you'll not be able to place your cup correctly. Because you don't place your cup at the flexion point, vacuum will not successfully deliver. And depending on the degree of the pelvic contraction, the vacuum, the faucet may not also work. And because generally faucets are more traumatic, they require extreme experience, it is not usually a routine instrument found in our labor ward. Of course, the baby is alive, there are no contraindications, you can do cesarean section. Rarely, where the skill is available, you may consider doing destructive vaginal deliveries if the baby is dead and you see this one is smelling, and if you do the CS, you are going to see the infection into the abdominal cavity, and you don't have the skill for the destructive deliveries. You can give us cesarean section. Symphysiotomy is also another modality, but I've not seen one because I've not even seen one who has done one. I've not had anybody who has done one because it involves separating the pelvic symphysis and then which will give you widen the pelvis a little bit and then you pull the baby out. But it's the post-op care that is more difficult. That's why people don't really do it. Next slide. Destructive operations. This could include when the baby is dead. The indication for destructive operations are: 1, fetus is dead; 2, the cervix is fully dilated; 3, there's an experienced accoucheur, somebody who can do it, has done it, has experience, right? And there's been properly taken consent. Without consent, you can't do destructive surgery. So 4 easy requirements: fetus is dead, cervix fully dilated, there's available skill, and there's consent. Because you're going to mutilate the fetus. And then they must be aware of what you're going to do. They must give you your consent and sign. So that when the babies, you bring out the baby, they will not accuse you of the ritual. All right? So different types of destructive operations include craniotomy, which involves opening the skull vault for some of the brain tissue to come out, for you to be able to decompress the skull and bring the baby out. You can also do cleidotomy, which involves fracturing the clavicle. Now, this is the exception. You can even do cleidotomy on a live fetus. You break the clavicle so that the distance between the 2 shoulders is reduced and you can bring the baby out. This is especially possible when you have shoulder dystocia and the baby is alive. Sometimes even when you have shoulder dystocia and the baby is dead, it's the simplest thing you can do to bring out the baby. You can do decapitation. Decapitation is done when you have impacted transverse lie with IUFD and the neck is accessible to you. You can easily get the neck and decapitate and deliver either the head first or the trunk first. Embryotomy is done, this is called evisceration rather. Evisceration or embryotomy is done when you have impacted transverse lie, but the neck is not accessible to you. In that case, you can go through the axilla to decompress the chest, pull it down so that the neck will become accessible, and you now do decapitation and deliver them sequentially. Next slide. Next slide, please. Next slide. Next slide. So, hello. Next slide. Okay, stop. Okay, let's see. Please. Dr. Ben. The previous slide. Okay, good. So next slide. Okay, so what are the potential complications from destructive surgery? Now, one of the most important, I mentioned 4 requirements, right? The 5th requirement is that you must rule out uterine rupture before you do destructive surgery. You must rule out uterine rupture before you do destructive surgery. Reason is that your procedure can also rupture the uterus. So if the uterus is already ruptured, your procedure will make everything worse. So you must rule out uterine rupture before you do destructive surgery. What are the potential complications of destructive surgery? Rupture uterus. Oh, sorry. Of obstructed labor as a whole, rather. Now, rupture uterus, VVF, RVF, peripheral nerve injury, particularly the posterior tibial component of the sciatic nerve, which will result in foot drop. The patient may have secondary amenorrhea. She can develop osteitis pubis. She can have pressure sores. Next slide. In conclusion, obstructed labor is a marker of the neglect of women in any society. It has disastrous consequences, and women who survive the initial assault caused by obstructed labor are likely to suffer prolonged or permanent health consequences. Effective prevention requires the provision of comprehensive emergency obstetric care at least the district level, which would involve a full range of nursing, medical, and surgical services. These are often lacking in most of the developing countries, and that is why obstructed labor is still a dangerous challenge in women's health in developing countries. So how do you prevent obstructed labor? Solution lies in preventive measures. This includes establishment of good primary health care facilities where good antenatal care will be provided. Women who are potentially to develop complications will refer to the higher level of care. And of course, for this to be possible, there has to be adequate mode of transportation, which will only be possible that are good roads, good road networks. Then, of course, the manpower will be trained to identify complications that are beyond their capacity to handle and refer patients in a timely manner. Next slide. So this is the end. We can look at, when we come to the revision before the exams, we look at the strategies for prevention of obstructed labor, primary, secondary, and tertiary level. All right. So please, any question? Any question, please?
Hello, good afternoon, sir. Oh, evening, sorry. I have a question.
Okay.
Well, so it's a slight tangent for related to obstructed labor. With regards to pathograph, how would
Okay.
you be able to separate obstructed labor from prolonged labor?
The pathograph, if you look at the pathograph, it tells you clearly the duration of labor, right? The average duration of labor should be 12 hours, right? Active phase of labor should be 12 hours. So using the pathograph, you know when the labor is prolonged. Now, how would you know that the labor is obstructed? It's based on your assessment of the descent and the findings on vaginal examination. In the pathograph, you have where you plot your descent as a cycle, right? Either it's either 3/5, 2/5, depending on the descent and the extension. Now, also remember that just below the fetal heart rate, there's a place where you describe your liquor. It's a place where you describe the degree of molding, right? So, when labor is prolonged, the major problem is the duration is lasting more than 12 hours. But when labor is obstructed, you either have an abnormal presentation. For instance, she's breached. The woman came to you with breach in labor, and she has been and she's 6 cm, and the breach has not engaged for more than 46 hours. No, that one is obstructed. Now, what else will show you obstruction? When you have any evidence of maternal and fetal distress. When you have fetal tachycardia, fetal bradycardia, meconium sin lico, in the presence of a situation whereby this labor will not be, this baby cannot be delivered without a CS or a vacuum. That's one. So in essence, a labor can be prolonged but not obstructed, but a labor can be obstructed without being prolonged. Let me give you a simple example of how a labor can be obstructed without being prolonged. A woman goes into labor with the transverse line at home. She started contracting. They took her to a primary health care center. And then in the course of labor, the membrane ruptured and the hand came out. Already this impacted transverse line of hand prolapse. That hand will never go back. That baby can never be delivered until you do CS. That's an obstructed labor. But it may not have been prolonged labor, right? But you can have a labor that is prolonged and obstructed. She started with a cephalic presentation. She labored, and then in the course of labor, the head was not descending. She started, let's say, at descent of 3/5. Then after 2-3 examination, the descent was still 3/5. And then maybe, let's say, it became 2/5, which means at station 0. And now, in the course of doing the vaginal examination, initially there was no caput, no molding. Gradually, now there's increasing molding after 2 examinations. Initially, molding was 1+, now it's 2 or 3 pluses. It means this one, and then there's no fetal distress. Maybe the heart rate now became 180, and when they did ARM, the meconium became stained, and the woman became dehydrated. She's in pain. So these are features of obstruction. Now, before I conclude, I'll give you another thing to know. Between obstructed labor and cephalopelvic disproportion, what's the difference? In cephalopelvic disproportion, the woman is having adequate uterine contractions, but there's no further descent of the presenting part. So she came to you at station, the descent of 3/5. She's having 3 to 4 contractions in 10 minutes, lasting 30 to 40 seconds, even lasting 40 to 60 seconds. But that head, after 2-3 examination, has been at the same -1. And now there is caput of a molding of 2 pluses. It means the head has not been able to pass into the birth canal. That is a CPD. How you differentiate is that CPD can ultimately result in obstructed labor when the labor continued, that head did not come down, molding became 3 pluses, caput became severe, and the baby developed because she now got tired of the labor. She became dehydrated. She became febrile because membrane has ruptured more than 12 hours. So this is now obstructed labor, which means obstructed labor can develop from a prolonged labor. but obstructed labor can also develop without prolonged labor. You understand me now? Hello, Terry, you understand?
I do. Thank you very much.
You're welcome.
Yeah.
So you know that question, please. So if you don't have any question, we're going to look at urinary tract infection because the slide that I've seen requires update. So I'm going to update it. So between Saturday and Sunday, I want you to choose a time and let Dr. Ben know. I'll finish the slides and then we'll have a lecture that'll be a bit more comprehensive on urinary tract infection and pregnancy. All right. So ladies and gentlemen, I think we've come to the end of today's presentation. So I will see you next time. All the best. Keep on reading. The exam is in about a month's time, right? So I wish you all the best. Bye-bye, everyone.
All right, thank you, sir.
You're welcome.
Thank you very much.
You're welcome.